lumen to allow air in and out. So large normal lumen. On the specimen below, which is of the same size, on the section below, then this is fibrous tissue here, which has accumulated in the lumen due to chronic, repeated infections, repeated inflammation, and resolution with scarring. And of course, once this fibrous tissue is deposited in here and the scarring begins, then it means that the surface is irregular and infection can occur more easily and expectoration of mucus becomes more difficult, resulting in stasis. So the whole thing can be a bit of a vicious downward spiral. So an obstructed bronchial lumen, as occurs in chronic bronchitis. Now here we see an X-ray of someone with chronic bronchitis and emphysema. And the first thing to notice is that there's a lot of air in the lungs, that the patient is unable to breathe out. The lung fields are very dark, meaning there's a lot of air in them. And the diaphragm's low. The diaphragm's flattened because the lungs are overexpanded. And in fact, the lungs are a good couple of ribs lower than you would normally see. Normally the diaphragm will be fairly well domed up like that. So lung fields are a couple of ribs lower than you would expect in a healthy lung with a flattened diaphragm. So the lungs are overinflated and blackened. And the reason this patient actually came in, sorry, not literally blackened, they're blackened on the X-ray because there's a lot of air in them. And the reason this patient came in, we can actually see down here, there's a left lower patchy consolidation here. The lung tissue to some degree has been made solid by infection. And I think you can see around about this area there's evidence of fluid in the lung tissue and consolidation. So what's happened here is that there's a patient with chronic obstructive airways disease, chronic bronchitis and emphysema, and they've had an acute exacerbation in the form of patchy consolidation in the left lower lobe. So I've mentioned that bronchitis and emphysema go together, and we'll see why this is later on. But some patients traditionally have been referred to as emphysematous and some bronchitic. In other words, some patients seem to have more emphysema than bronchitis, and others that seem to have more bronchitis than emphysema. And there is some clinical application to this knowledge. And the patients that are mostly emphysematous are referred to as pink and puffing. They tend to be pink coloured and they puff and pant. And patients with bronchitis tend to be blue, i.e. cyanosed, and bloated. That means they retain fluid. And again, we'll see why these are. So these are the classic clinical types you might come across. Type A, referred to as pink and puffing. These patients are breathless. And because they're able to puff and pant a lot, they can blow out most of the carbon dioxide. And because they're breathing a lot, because they're puffing and panting, they can compensate for the lack of surface area in the alveoli to a degree. So traditionally in a patient that's pink and puffing, the arterial O2 and CO2 are relatively normal. In these patients, cor pulmonale, which we'll study in a minute, would not be a major feature. And in this case, the patients will be predominantly emphysematous with little bronchitis. So the pink and puffing type. The second type, the type B, are referred to as the blue and bloated type. And these patients are cyanosed and they are edematous, blue and bloated. They tend not to be as breathless as the pink and puffing type, but the arterial oxygen is low and the carbon dioxide is high. And this clinical type occurs predominantly in bronchitis where there's little emphysema. Now, having said that about the two types, the pathology that's actually found doesn't relate very well to the clinical picture, but there is some clinical application to it. And most patients are a combination of the two types. In other words, bronchitis and emphysema go together to give what we call chronic obstructive airways disease. Let's think about how common these conditions are. Well, in the UK, very common. About 17% of men in the age range 40 to 64 have some bronchitis and emphysema. So pretty common, nearly 1 in 5 there. In women it's less due to the fact that women smoke less, or traditionally have smoked less, and it's about 8% in the 40 to 64 year age range. And this condition seems to be becoming less common in the developed countries because to some extent atmospheric conditions have improved, or well, the atmospheric conditions are actually bad, but those that seem to particularly cause bronchitis and emphysema have improved. But the main reason probably is people are smoking less. But in developing countries where there's increasing amounts of air pollution, especially in the cities, and where there's more smoking, then bronchitis and emphysema is becoming more common. It's also fairly common in developing countries where people are forced to burn fires in the house to cook on and to keep themselves warm. In Nepal, for example, where a lot of people are forced to cook on open wood fires because they can't afford any alternative, then for years and years people are breathing in a lot of smoke in their houses, and they get this chronic bronchitis which can lead on to emphysema as well. So becoming less common in developed countries, but becoming more common in many two-thirds world countries. So increasing prevalence in many developing countries, decreasing in the UK. And it's an important condition because, especially in thinking about developing countries, it carries a considerable socio-economic burden. In other words, the people that are suffering from this condition should be economically productive people. They should be going out, planting the crops, working in the factories, bringing up the children, doing all the work that needs to be done, but they can't do it effectively because they've got bronchitis and emphysema. So it's a very important disease for us to prevent. People shouldn't smoke and shouldn't spend any amount of time in smoky environments. We must advise people against this because it's the inhalation of smoke that's maybe the main cause, in fact is the main cause, of bronchitis and emphysema. Let's go on and think about the clinical features of the condition now. Features of bronchitis and emphysema. Well, bronchitis, an acute or chronic inflammation of the mucous membrane of the tracheobronchial tree. In other words, it can affect all of the bronchial tree. So thinking about bronchitis now specifically, let's just get this clear. We're talking about bronchitis particularly. We're not talking about the features of emphysema very much. So features of bronchitis. We'll come on and look at the features of emphysema later on. So bronchitis, an acute or chronic inflammation of the mucous membrane of the tracheobronchial tree. And as we've said very often, this becomes chronic to give chronic bronchitis. One of the key features of chronic bronchitis is a very slow, insidious onset. Maybe over many, many years the cough will become progressively worse. So the patients don't realise they're getting worse very often. And it's only when someone like yourself actually sees them and says, just a minute, you've got a bad cough, and you can actually realise then that they are developing chronic bronchitis. So insidious onset. And this is why people often don't take measures to stop. You can listen to smokers with the most appalling cough, but for them it's normal. They don't realise this is abnormal. And it's only when they compare themselves to maybe to what they were 20 years ago that they realise there's a difference. So slow onset over often many years. So insidious development of a persistent cough, one of the features of bronchitis. Wheezing and shortness of breath, and progressive shortness of breath on exertion.